Everyone, welcome. I'm Cinda Rushton. I'm the co-chair of the Johns Hopkins Hospital Ethics Committee and also faculty in the Berman Institute. So welcome to our monthly Ethics for Lunch. And today we are going to be exploring the legacy of Baby Doe and the implications for parental decision-making. And in a moment, I'm going to introduce our panel, who's an incredible group of people. We have a few details on CME information. We have CMEs available for this particular event. We do not have any disclosures by any of our presenters. We aren't going to be talking about medications off-label. And here are our objectives overall in terms of all of our Ethics for Lunch activities. And here's our disclosure statement, and here are our objectives for today. And we are really happy to have all of you here with us. We're going to be talking about the Hopkins Baby Doe case. We're going to be talking about a moral framework for parental decision-making and look at the implications of the Baby Doe cases on parental decision-making and see if we can also come away with some ethically grounded strategies for supporting parental decision-making. We also take confidentiality very seriously, and as a result of that, you see the confidentiality pledge here. If you have any concerns about information that is here, the facts related to the Hopkins case are public knowledge, and they're not information that is not available in other ways. All right, if you're interested in receiving attendance for this event, first you need to text your email address to 1-844-980-1555. And then when it's connected to your device, you can then enter in today's code. And that is 57922. About this, check with us afterwards so that you can get CME credit if you would like to, and then also you can find your CME information here at the Hopkins site. So let's get started. I want to start by giving a little bit of context for our discussion today. Our panelists, who will introduce themselves a little bit more as they speak. Number one is Carol Long, who is a newborn nurse practitioner, former NICU nurse. Ira Berkowitz, who is a pediatric anesthesia and critical care physician. Meg Garrett, who is well known to many of us as the former director of risk here at Johns Hopkins, and also emeritus member of our ethics committee, and Renee Voss, neonatologist, member of the Berman Institute as well. So I'll let them give a little bit more details on their backgrounds as we move through the discussion today. But I wanted to frame the conversation a little bit in terms of what makes pediatric decision-making challenging. First of all, there's a lot of uncertainty surrounding pediatric care. Children are incredibly resilient in ways that we sometimes don't expect. And we don't always know how things are going to turn out, even with our best data. A lot of times there is an unpredictable disease trajectory. Children have surprised us, myself included, many, many, many times. And there's a tendency when we think about pediatric decision-making, especially around situations that could result in death is that it's often inconceivable for us to think about death in childhood. And so that creates a pretty high threshold for the kinds of burdens that we're willing to tolerate to give a child a chance for life. Pediatric decision-making is also complex because children are generally unable to speak for themselves. And so we are dealing with surrogate decision-makers in terms of their parents. And that, I think, puts us in a situation where we have a lot of ethical questions about how we balance the benefits and burdens associated with various types of treatment. Questions about who decides and what the scope of parental discretion can be in these kinds of situations. And as you'll hear, clinicians have an obligation to prevent abuse or neglect of vulnerable children. We also know that the context for parental decision-making is involves sometimes parental requests for things that may or may not be effective, and against the assessments of clinicians that what they are suggesting may be ineffective. We are challenged by how, as children grow up, how we involve them in decision-making for themselves, what a reasonable scope of informed consent would be, and can you ever be fully informed? And then issues of justice related to access to treatment and resources, and the potential for discrimination based on age or diagnosis, finances, or social factors. And you'll hear a little bit more about that. But to frame this conversation, we generally begin with the assumption that parents are the best decision makers for their children. And that is based on their biologic, emotional, spiritual bonds that have reinforced both a moral and a legal presumption about their role in decision making. They have a legal and moral responsibility for the welfare of children, but there are also limits. Their authority is not absolute, and although there is quite a bit of latitude. So just to begin thinking about the case that we're going to present, one way to think about parental decision-making is whether they meet the reasonable parent criteria, which means that they're able to prioritize the child's welfare. They have the capacity to comprehend the essential information about the child's condition and prognosis, and then finally, capable of making an informed decision. So if we start with that sort of broad context, what we're going to delve into today is a case that happened here in 1971. And we are going to share a clip from a longer video film about this case that happened here at Johns Hopkins, involving a newborn baby with Down syndrome and duodenal atresia is an obstruction in the outflow from the stomach into the small intestine. And without it being open, it's not possible for a baby to survive normal feeding. All right. You ready? You want to say anything, Carol?
No, I'll say this: Baby Parks is in the movie. Do
you want to use it, Mike?
Can you hear me? Marie Parks, who was in the movie, is here with us today, and hopefully we'll get a chance to ask Marie what it was like in 1971.
That's it. I'll go call him. He looked very much like a child that you would have found abandoned somewhere and left to die in a garbage can. I can remember the parents and the decision and my agony, and I knew that I was partly responsible.
That's a good push.
That's terrific.
Let's have another one. Now you relax for a minute while we listen to the baby's heart.
We're going to plus 2.
Good girl. Keep at it.
No, it hurts.
Good girl.
Here it comes. Okay, now we get the shoulder. Good.
Okay, baby. Come on. Let's fuss a little.
Here's a boy.
Dr. Villafani, is the mother awake?
No, she's up.
This baby looks a little mongoloid to me.
The diagnosis of Mongolism can be made with a fair degree of certainty in the nursery. In addition to the Mongolism, the patient had this disorder called duodenal atresia. There was no opening between the stomach and the lower intestine.
A child with duodenal atresia doesn't look to be any...
Dr. Haller knows a good deal about Mongolism and has operated on many Mongols with problems.
Doing fine. He's well hydrated, and we have an IV in, and the NG tube is in, and
So as far as you're concerned, we're all set to go in the morning.
right.
There's some possibility that they are not going to want an operative procedure on that baby. She's a nurse and apparently has taken care of some children who were Mongols in the past and has some real serious reservations. But
The presence of a lesion that was incompatible with life allowed them to make the decision about whether they not only wanted their Mongol child, but whether they wanted their Mongol child to live or die. The child's life, if you look at a Mongol's life, was not one of pain or suffering or misery, or that he would never learn, or that he would never know himself, or that he would never be an individual. His life, although certainly not normal, would be a life. I mean, he would be a living human being.
making an opening so that the contents can go through all right. And so as you can see, it's a relatively simple operation, but it's in a fairly small baby. And for that
Dr.
reason,
Haller wanted to operate on this patient. He did tell the parents, however, that it would be their decision.
But the operation will have no effect whatsoever on his underlying Mongolism, because this is a condition which is separate from, although it may be related to, the abnormality in his intestine. The Mongolism condition is not going to be changed by fixing his intestinal obstruction.
From the parents' standpoint, they were looking forward to having this bouncing, happy, healthy baby, and then some physician tells them that their child is a Mongol. Why burden ourselves? Why burden society? Why burden everybody with this defective child? Why not simply let God's will be done? The parents don't want any operative procedure to be done on the baby. And Dr. Haller has decided to respect their opinion and their belief about what they want done to the child. So we're going to stop any artificial means of prolonging the baby's life. It was a long and agonizing wait. I was very concerned about what this was going to do to the nurses. Their initial reaction was one of just kind of horror and disbelief that we were going to do this. We were going to take a baby who was completely healthy baby compared to a lot of the patients they were taking care of on the floor, who was now going to go into a bassinet in some dark corner and starve to death. It took 15 days.
So the question here, and this is in 1971, was, do all children have a right to life? And just before we have any comments, just to notice what has come up for you as you have witnessed this documentary of this case. And one of the important things about language, you'll notice that we no longer use the term mongralism. We have shifted our language to children with Down syndrome, children first. So just to notice a shift in how we as a community have shifted over these many years. And yet there's a lot in this case that I think is relevant today in terms of how we think about the lives of children who have similar diagnoses and how we as a community in healthcare, how we respond to it. So I wanted to turn to Carol first and ask you to reflect a little bit in terms of, as a neonatal nurse, I know that both Carol and I have a lot of connection to this series of cases in our own careers. So Carol, use the mic.
Thank you, Cinda. I think I saw this movie in nursing school probably in 1978. And I didn't know at that time I was going to be drawn to pediatrics. I was interested in maternal child health. And I remember thinking that the parents, you know, you could understand, because there was a part of this movie, they talk about the parents' perspective, which was held strongly. But I thought, but to leave the baby in the hospital rather than take the baby home, that it was just I don't know, it caused a lot of distress in me that the nursing staff had to facilitate this decision that the parents made. And I guess in talking to Marie, I've learned further that this baby wasn't born at Hopkins. It was transferred in for Dr. Haller's service. It was on GPS, the General Pediatric Surgery Service. So this was not what most nurses were expected, you know, their role to be. And then since that time, so much, so that was in the early 70s. And I guess the legislation and the cases that kept happening didn't really get traction until the 80s. And we really started looking at the role of the parents. But so I think it's interesting too, that this is one of the first cases that really started the whole idea of bioethics, and a lot has evolved from this Hopkins case during the 70s, which was sort of a quiet period for what was going on in nurseries. Thank you.
I think, Carol, just related to that as well, at that time, we didn't have the language as nurses and as clinicians to describe our distress and why this was what we now call moral distress, in recognizing a situation where there's an ethical problem and coming to some conclusion about what ought to be done, but then having constraints on being able to do that. So this really preceded our vocabulary even of what we carry as clinicians who were bearing witness to this process. and participating in a variety of ways, both in the decision-making process, but also in the moment-to-moment care, which nurses 24/7 were involved in caring for this child during this process. So thank you, Carol, for that. Ivor, you want to talk a little bit about the ethics component of this?
So I'll make some comments about how we now sort of address these, sort of complicated decisions, you know, in 2023, 24, and how we resolve this conflict. This was the issue clearly faced by the surgeons and the healthcare team at the time of this Baby Doe case, and it persists to the present time clearly. We need to balance the physician's assessments of the child's well-being with respect for the parent's wishes and the legal rights. Particularly, what are the limitations of the parent's rights to refuse treatment? And this has clearly changed now. How does the clinician resolve conflicts between the parent's values and his own medical and professional judgment? And at what point may the clinician or should the clinician reject the parental decisions to repudiate the clinician's recommended course and then seek state agencies, child protective services, or legal jurisdiction? And this is where we'll go. We have several guiding sort of principles that I'll talk about. The first is what we refer to as the best interest standard. We've mentioned, and it's come up, that children really lack the legal decision-making authority for most medical decisions. Clearly, neonates don't have it. And so the decision-making falls to the parents in collaboration with medical providers in a process that we refer to as shared decision-making. And this is the model that we use. It's guided by the ethical principle of beneficence. And we follow the best interest standard, which is a decision that is made to maximally promote the child's well-being. The strengths are that it's sort of aspirational. This is the standard. This is what we seek for. And it's widely accepted as a guiding principle. It has strengths and it has weaknesses. And I think the one weakness is that when you think about what is the best interest of the child, it's sort of ill-defined and a little bit inconsistent as to, you know, what this really is and what the range of the benefits and the harms that ought to be considered. And also it's difficult clinically to assign this value of benefits versus the harms. In general, parents are granted a wide latitude. So we tend to go with the parents' decisions, but at some point there becomes a limit to that where we are not prepared to really go along with what they want. The one sort of other weakness is that when we make these decisions, it fails to really respect the family as a whole, because, you know, this is a child that fits into a family and other people in that family have some interest in this kind of decision. This is not a Downs example, but consider a child with a very malignant brain tumor. And the neurosurgeon, neurologists suggest a particular kind of therapy that for this child in Boston is in Baltimore is only available in Boston. There are 4 other children. Should the whole family move, the other children have to go to school. The parents will lose their jobs. You get a sense of what this means by incorporating the sort of best interest for the whole family. But generally speaking, parents are granted a wide latitude, except when the health of these children are in jeopardy. There is a criticism that sometimes this best interest may confuse caretakers, particularly the issue of when these refusals should be tolerated. There are competing views, and I just want to mention at this point that other people have suggested, Dikema in particular, who articulated the harm principle in a sort of a sense to remove this confusion of benefits versus harm, and he placed more weight on the fact that we would get to a point where we have to evaluate harm, and at this point we could not accept the decision of the parents. This harm principle will focuses on whether the child will be harmed by the parent's choice and not what is optimal. And this is regarded by medical ethicists as perhaps more appropriate than the best interest standard. The decision of the parents to refuse medical therapy should not increase the risk of harm to the child. It's accepted as an interventional principle, and so we use this principle when the parents place this child at risk, and helps with the physician's ability to the physician's ability to override the choice of the parents' resistance. Other people have. I could have the next slide. Thanks. Have presented this issue of the zone of parental discretion as a sort of way of considering both the best interest standard and the harm principle, and how we can consider both of these. Sorry, we can think about the best we can think about the best interest at the top of the sort of hierarchy, that we are going to make a decision based on the best interest up to a point where the issue of harm rears its head. And this area between we can refer to as the zone of parental discretion, which is sort of ethically protected space where parents may legitimately make decisions for their children, even if those decisions are suboptimal. They may not be the absolute very best for the child, but they're still okay. And then the next slide will show this in a sort of a schematic way. You get a sense of this blue area, which is the green area, which is the area of best interest for the child. This is our sort of overall goal. We then have the boundaries of this is the area of harm to the child. And then that gray area is that zone in between where it becomes acceptable to accede to decisions of the parents. Clearly, when there's harm and we're extending into the blue area, then that's the point where we might consider referral to child protective services, or obtain legal consultation to perhaps remove the decision making from the parents.
So thank you, Ivor. This is I think what we're illustrating here is in 1971, we didn't really have a very explicit moral framework for parental decision making. And that case in 1971 and the subsequent Baby Doe cases in the 80s that involved various other congenital malformations in children, myelomeningocele and others, really pushed us to this point of trying to define what are the boundaries of parental authority. And, you know, another way to think about this is clearly beneficial treatment. When we know something is, you know, there's not a lot of risk to it and it's clearly beneficial, then that is a kind of intervention that has obligation that goes along with it. On the other end are the things that we know actually aren't going to be of benefit, but may ultimately be harmful, that actually are causing more harm than good. And so this zone of parental discretion is where we defer to families to make those decisions based on their particular values. And that is still a gray zone. I think the gray zone in the middle is where a lot of us have to struggle with the uncertainty of, is this beneficial? And how do we understand benefit? And is it harmful? How do we understand what kinds of harms count? So that's kind of the context of where we have evolved to. And Meg, I'd love for you to talk a little bit about the legal framework, because it certainly was a major driver in terms of how we approach these questions.
Can you hear me?
Yep. Hold it close.
Thank you. Thank you for inviting me today. First of all, I want to say I am a nurse. I started practicing as a nurse in 1972, was a Navy nurse during the Vietnam era. And what does that have to do about Baby Doe? Well, I graduated from Villanova and my first duty station was in Boston. For the first year, I worked in orthopedics, which was pretty horrifying with all the young men coming back from the war. And then out of the clear blue, they asked me as a 23-year-old to be in charge of the newborn nursery / NICU / whatever it was. And at 23, we had similar cases. It would have been 1973. And I remember walking in one day early in the morning and seeing a baby in the treatment area, just kind of lying there, a newborn. And, you know, the child had several deformities and so on, none life-threatening. Mom was 18 years old. Dad was in a rice paddy in Vietnam. And mom had made the decision that she really couldn't take care of this child. And the physicians agreed to let it go. It was a time of significant moral distress for me, seeing not only our young 18-year-olds dying and maimed, but the thought of this little 6-hour-old baby, and pulled a number of the physicians together, as well as clinicians, and the decision was made to override mom. And that little child ended up coming out of the nursery, and to my knowledge, I have no idea, but it was a very challenging situation. Around that same time, 10 years later, and actually I had gotten out of the baby world and so on, but ended up in the psych world, which is probably a good place for a lot of nurses to be. And then I actually ended up going to law school in early 80s. And these cases were starting to come down the pike. And I'll be honest with you, part of my reason for law school was to be able to protect my nurses. I started the American Association of Nurse Attorneys in 1983 with several people from Maryland. And because we as nurses were, and nothing against physicians, I was married to one, but essentially as the nurse, we were there 24/7 and had to deal with, and we still have to deal today with the pluses and minuses in healthcare. So Baby Doe restarted, and there were a number of cases. Hopkins, clearly had its case, but having talked to a number of people at Mass General, Cleveland Clinic, across, nurses across the continuum, the 70s were really challenging and very challenging for physicians who had to work with families and make these decisions. And I'll go on to explain this a little more. Baby Doe was born, you can see with Down syndrome and a surgically corrected esophagus. Determined a child would not lead a quality of life, refused to consent to corrective surgery. My little one in Boston ended up eventually getting transferred to Boston Children's and being taken care of. And they the hospital sought judicial guidance and reported the parents' non-treatment decision to the prosecutors. Monroe County upheld the parents' decision to withhold. Indiana Supreme Court refused to hear. The baby died 6 days later, and this hit somewhat of the press. It wasn't internet back in the day, so it didn't, kind of just floated around and so on. So as a result of that, the Reagan administration decided to come up with what they called an interim final rule. Anybody practice here in the 80s in the pediatric area? At that time, the interim rule required that you have a posting in the hospital that said that if anybody's doing in the clinical pediatric area, if anybody's doing anything inappropriate, i.e. related to discrimination and so on, that they had to report it to a special number. Between the time of the rule, there was another case at Long Island, and let me tell you, everybody fought the rule. American Academy of Pediatrics and so on. Neonatologists, kind of like OBGYN today, were pretty anxious about how they could practice, what they could do, what they couldn't do. I mean, they really put on the provider that they had to save the lives pretty much of every child coming down the pike. Anyhow, this was a spina bifida baby. Hospital lacked the legal authority to perform the procedure without parental consent. And they complied with the parent's choice, which was to forego intervention. But it continued for a very long period of time. After the second case we talked about, they came up finally with a rule that it came down under child neglect, the child abuse laws, which came under, state jurisdiction as well as one part of the federal rule. And basically, it was the decision that anybody who decided to withhold treatment in patients, it had to be, it would be child neglect if indeed there was any chance of survival for this child. It had to be the baby was comatose, medical futility, and other of those related issues. And that's still where we are. Currently, we have a mandatory duty to report to Child Protective Services any situation where we feel a child has been neglected or abused. I know it's challenging. Any social workers in here? I know it's very challenging because some of those statements have been questioned from a legal standpoint over the last year or two, but we still have a mandatory duty to report that. One of the interesting cases post all of this is we had an ethics consult about, probably 10 years ago, probably the longest consult ever, maybe 12, 13 hours. I got a call in the middle of the night from the general counsel saying, you need to report these conjoined twins to Child Protective Services. The mom does not want to do surgery to separate them. And we think this is medical neglect, medical abuse, you name it down the line. And I said, well, we need to talk about the case first, as some of you in this room were on that case with me. And I said, do we really need to look at this? I mean, are we allowing this mother, illegal immigrant from Guatemala, who was maybe 19 or 20 years old, who said, I want my babies to die together. I don't want to do anything to separate them. I don't want to do anything else. And we started the consult probably at 10 in the morning, and it lasted pretty much all night long without calling Child Protective Services at that point, because I didn't feel the children were in immediate need. And we ended up, by the end of the session, I think Ben Carson was in it. We had a number of people. And by the end of the night, it was totally unfair to save the life of one child for the other, because that child would have to be on life-sustaining treatments and so on for the rest of its life, whatever period of time. I think one of the better outcomes of all the ethics consults involving children here was that we did genetic testing to determine what the sex of the children were. And we had them baptized in their mother's arms. But believe me, the organization, I forgot what year, 90s probably, 90s, 2000. Yeah, 90s, 2000, something. Yeah, but it was, several years ago, but there was still the angst that we were allowing babies to die and that kind of thing. And I think at the end of the day, we all felt very comfortable with the decision that was made. Fundamental, and I've already talked about it, what's the best interest of the child? Infants in need of protection versus futility. I mean, that's one of the common questions we get from an ethics consult, period, whether it be a guardian or a parent or whatever. The amendments have ruled out quality of life as a factor in making decisions. I mean, anything with Child Protective Services, it's not whether it's the best interest, it's just whether it's medical neglect. Parents can refuse when they feel that the quality of life is not worth the pain, suffering, and so on, still challenging. The implementation of the amendments in 1984 may in some cases be instrumental in coming up with the whole child abuse thought. So in conclusion, issues surrounding care for critically ill newborns and children, and especially newborns in today's world, are complex and problematic. Child abuse surveillance have reduced parental authority, as well as in the decision-making process, as well as the authority of physicians. Definitely a challenging time for you all in medicine and nursing. Additional players in the decision-making process who may be effective. Certainly other caregivers, thank heavens we have ethics committees. We certainly didn't have them when I had my cases back in the 70s. We definitely have a whole back row of spiritual advisors. I'm very happy to see all our chaplains here. And the courts may be the final arbiters. And there have been a couple of cases that we almost had to take to court. Certainly in guardianships with adults, we've had to take to court regarding care of patients and futility and so on.
So thank you, Meg. Just another piece of the story here in my own journey as a nurse. I started out in the PICU. I remember well those signs posted in our critical care unit about reporting any situations where there were questions about the decision-making. I then became a clinical nurse specialist in pediatric cardiology and thoracic surgery, and then later neonatology and general pediatric surgery. So the case that, the Hopkins case was a case that I had experience with. And at that time, one of the outcomes of the child abuse amendments was the creation of infant care review committees. And because of my role as a clinical nurse specialist, I had often been involved in helping parents make those decisions. I was asked to represent nursing at the Children's Hospital in Atlanta in that infant care review committee, which was designed to provide a different level of oversight around these decisions. That infant care review committee model was the precursor to modern day ethics committees. And so that was how I got involved in bioethics, was kind of by accident, being involved in those kinds of cases, which then led me to get further education. And I actually did my dissertation interviewing parents who had infants with life-threatening conditions to try to understand that perspective. So you can see all of us have been deeply impacted by this series of cases. So Renee, tell us how far have we come?
Well, I guess before my slides, I want to say a couple of things. So one is that this particular scenario we're talking about, where families are refusing care that a majority of the medical team thinks is in the child's best interest, are the least common cases that we experience in pediatrics. It's the most common cases that everyone agrees. The second most common case is that parents actually want to go much further than the medical team thinks is reasonable or right or best, et cetera. So this is a very small number of situations that we experience in pediatrics. They're very distressing and obviously have a lot of ramifications, but they're uncommon. The second thing that I want to say is much of what we've heard about was before the advent of pediatric palliative care. And I think that for me, when I watched that initial movie, one of the hardest things for me to watch is, sort of the idea that a kid was brought to another room and just left to die. That there are many things that we can do to make the dying process more comfortable, can make the dying process more humane, more family-centered. I think the question about why the baby couldn't have gone home is an interesting one. Today, the baby could have gone home with the help of home hospice, could have met the rest of the family, slept in the family's bed, had photos with the family, done whatever it is. So we've grown a lot in our sense of what can be done to provide a humane and loving and comfortable death for a child. I spend a lot of my time as both a neonatologist and a palliative care doctor helping families think through these decisions. And what the movie showed us today was nothing about where the family was coming from. And as I think it was Ivor that talked about, maybe they had 5 other children, and maybe, dad was going off to Vietnam, and maybe, I don't know what it is, but most families in these scenarios are making caring and thoughtful decisions, and are not bad people who are trying to kill babies. And I do think that some of the rhetoric around that, and frankly, some of the rhetoric that we're hearing now related to abortion, is very inflammatory and very much simplifies the story of what's really going on for most of these families. Most of these families are very thoughtful, and this is not an easy decision. And okay, so I'll say that. So ethics consults, where are we now in peds? Reflecting what I said earlier about the most common scenario we have in peds is that families want more aggressive, prolonged care than the medical team thinks is reasonable. The number one reason why ethics consults happen in this hospital is because the medical team thinks that the prognosis for the child's quality of life is very, very poor, and the parents continue to want more therapies, more interventions, et cetera. Another common reason, and I have to thank Dr. Shannon Barnett, who collected these for me, so thanks to her. Another common reason is that we are worried that parents aren't actually the right advocates for their child. And there can be a variety of scenarios for this. Maybe there is a question about child protective services and whether actually someone originally did harm to the child and that's why they're ill. It can simply be that the family, for whatever else they have going on in their life, just is not in a space where they're really able to think about the child separate from themselves. And really, Cinda raised the point at the very first slide about how in pediatrics we have surrogate decision making. And I would say, not quite, right? Because surrogate decision making is, I make a decision for you based on what I know about you from, but I think what happens with families is that we're way enmeshed, and parents are way enmeshed for their child. And I don't think that not all families can sort of separate and think about what's right for the child versus what's right for themselves. Another common reason is parent behavioral challenges. Certainly we have families where, security is getting called and the staff is feeling actually endangered by them. This next reason is super complex and becoming more common, which is that our medical capacity to do things for children is meaning that we have a growing group of kids who are reliant on medical technologies that are really hard to manage at home. So ventilators, feeding tubes, dialysis, VADs, parents early in a child's illness may say, absolutely, of course I want you to do X, of course I want you to do Y, and maybe the doctors think, oh, sure, that makes perfect sense. Let's go ahead and do an X and Y. And no one's really thinking about 8 months in the future when this child potentially is ready to leave the ICU, but the family, it turns out they don't have a home. So those are very complex things. And then adolescents who refuse interventions like cancer therapy. So those are the most common reasons why ethics is consulted in this hospital. So I think there are some new flavors of challenges related to parent decisions in the past, I don't know, let's call it decade. Maybe even in the past 5 years. And one of them is really the increasing access that families have to medical information. So the Google phenomenon of parents, getting online or talking via Facebook to families who might have similar conditions about looking for alternative treatment options, looking for alternative diagnoses, looking for the reasons why whatever answer that the clinical team is giving them that they don't like, why there might be another answer out there. And, sometimes these scenarios result in beautiful miracles that get made into movies. where the family, advocated and found the magic cure, and now there's a whole foundation and lots of kids have this possibility. Those things happen. What's most common is that really we just end up not trusting each other. And so families don't trust the medical team knows what they're doing, that we're offering similar things to the same, to similar people, et cetera. So there's a lot of mistrust. I think also we don't get a lot of training on how to do shared decision-making. I never got any formal training on how to do shared decision-making. I watched some people do what I guess was shared decision-making, and then I was sent off to go do it myself. That's how I got trained to do it. And so what's happened is that we've totally swung from an era in the 70s, maybe before, where the doctor said we're doing this and so we're doing this. Now it's totally over here. And now the families are often, in fact, that's not true. Some families become demanding of care and want to basically compel us to do things, even if we clinically don't think that's right. And there's data showing that we do that actually on a regular basis. We do defer to parents' preferences. And I think what it ends up happening is that it really starts to become about the parent and my relationship, and my focus becomes about the parent and not about the kid. So as Meg pointed out, we do have some tools in our toolbox, and all of these are helpful in different scenarios and different situations. Sometimes we do really come down to heavy hitting, which is involving things like DSS and the law. And then my last slide is about social context, and that is that a lot of the intensive therapies that we initiate in the hospital have implications for long-term care by families. So trachs and vents, dialysis, various kinds of medications, et cetera. And or it is true that we prolong the life of the child, but they will have lifelong intensive cognitive, behavioral, functional needs that truthfully our society does not support. So those of you who don't work in this space probably imagine that there's plenty of home nursing available for children who need it, or there's plenty of physical therapy services, or that of course insurance provides all of the therapies. That none of that is true. And so our society is not living up to the demand for these situations. And so what that sometimes ends up meaning is that while the parent may want those things and may want us to proceed with those things, the reality is that they can't provide them at home, in large part because the society doesn't support them to provide those at home. So I think there's interesting growing questions about what our responsibilities are as a healthcare system to provide these things. Maybe questions about how transparent we need to be upfront to families. In Canada, actually, they're relatively transparent with families early on in the course of illness to say, just to be 100% clear, like your child won't be eligible for all these services. So if we move down that pathway, this financially 100% becomes about you, et cetera. Those conversations are held transparently in Canada, several miles away from here. So I think there's interesting questions about whether we should be doing the same thing, given the lack of our society investment in providing those services. And then there's obviously lots of questions about justice and equity. And does it mean that only families who don't have cars and don't have a lot of money are, their children are getting different services than families who are have different resources? So huge topic. What I would say is what we've mostly been doing in medicine up until now is just ignoring that this is true and pretending like it doesn't happen. And it's almost a taboo to talk about social context or families' finances or jobs. But I would put forth that actually helps nobody.
So there's a lot here to dig into, but before we begin, I want to give Marie a chance to just reflect on your experience of the Hopkins case just for a moment before we open it up for everybody else. So you're welcome to come on.
Hello, everyone. I was one of the nurses that took care of Baby Doe And contrary to probably other beliefs, the baby was not by any means ignored by the nursing staff. The baby was washed, bathed, held, rocked, and cared for. And the sad thing is that the nurses really did bear the brunt of all of this. The physicians would come by in the morning and make rounds, and then they'd come by in the evening and make rounds. And that was pretty much the extent. We never did meet the parents of this child. Now they may have come when I wasn't on shift, but it was never documented in the medical record, to my knowledge, that a parent ever came for a visit. And they did have two other children. They had two older children. I'm not sure how old, like 2 and 4 or something. And I still have profound sadness over this poor little baby that could have been a joy to this family if they had just looked beyond the Down syndrome piece of it. And I think most of the nurses felt the same way about that. Okay, thank you.
Wonder if Patty Binding, who a revered member of our pediatric community, I know maybe you have a reflection.
Oh, it's that one. That one, yeah. Probably you heard me anyway. I was a medical student when this happened, and I was shadowing John Freeman, who was Carol Bad, who was clearly beginning to, I think, evolve his own interest in medical ethics at that point in time, and this case certainly affected everyone, as you can tell. One other thing, though, I think to say in terms of the time context in which this happened is that society was only really beginning to think about how we would actually be able to help children with disabilities better. And if you think about it, it was only in 1963, in the mid-60s, that you had the beginning of things like our Kennedy Institute over here, university-affiliated centers that would really, I think, bring care for these children into a better focus and be able to help educate the medical community as well in terms of what their prognosis would be. And it wasn't until 67, so just before that, that the Kennedy even opened. So, I mean, I think you have to think of that time as well. You know, lots of children with Down syndrome were placed in mental institutions, Rosewood. Exactly. So I think when we think about quality of life for a child with Down syndrome today, it's very different from what it would have been like in the late 60s, early 70s. So when I got this announcement, I went, oh my, you know, I do remember, you know, being on the wards when we were facing, you know, what to do.
So just a historical context, you know, obviously these cases have had a huge impact on all of us and also continue to, you know, as we try to sort out these new boundaries. Wonder if anyone has any questions for our panel that you'd like to raise.
I just want to make one comment about the oversight concept. I wanted to suggest insight as a thoughtful term in terms of what we're trying to provide there is insight. It just struck me.
Hi. I was wondering a couple of things. I was wondering about what support you got, the nursing staff got, because what an enormous burden, extraordinary burden it was for you. The other thing, is this a real film? Do they why were they filming it? I'm curious to know.
Two things, we didn't bring this up. This case was taken to the courts and the courts upheld the parents' wishes. So we didn't mention that. Dr. Cook, who was the chairman at the time, had 2 children with Cree de Show. And so as people, you can talk the talk about what do you do when. He and his wife, they had many children, but 2, not 1, but 2 had this severely disabling condition, and they lived at home with the family, I think, until they were 18. And so he had a close relationship with Eunice Shriver, and the Kennedy family's foundation was just emerging. So he said, you know, I think we ought to talk about this, and he appealed to the Kennedys, and thus the movie was made.
And just in case you're interested in the whole thing and the materials that go along with this recording for Ethics for Lunch,
They have the whole
link
panel.
to the entire documentary. So thank you for that. Any other questions?
Would you be willing to, you know, I think I'm not.
No.
No, they're not going to hear you.
Okay. Could you be willing to share some of your successful strategies in actually dealing with these kind of collisions between medical recommendations and parental decisions, maybe guided by cultural beliefs? What have been some of your successful strategies in dealing with such situations?
I guess in my experience, communication is probably 95% of it. So committing to continuing to talk with families about like, where are they coming from? Why do they have the goals and the values that they have? Can they tell us more about that? And if there are pieces of that that could be better informed, maybe they're working with partial information, and maybe that partial information is medical. Sometimes it's spiritual or religious. So sometimes they have they've inherited beliefs through the family about what their religion might say about X or Y. And so what resources can we bring to bear so that the family is working with the best information that they can? And then it's communication on our part too. So maybe we were going down one path and the family wants another path, but maybe there's a third path. Like, what can we imagine as the possible compromises, I guess I would say. And in my experience, probably 90 to 95% of these scenarios you can resolve through compromise. You can eventually get there, maybe not as fast as you want. Maybe each of you gives up a little bit, but I think most of the time we're able to resolve. We use those resources for sure. So ethics, palliative care, spiritual care, you know, every resource that we have to bear. But I would say much of the time we can find a space together.
Just to sort of complement your comment and in answer to your question, particularly emphasizing the issue of the cultural aspect, I think what is in addition particularly helpful is having these group meetings, but then incorporating into the meetings, you know, clergy was mentioned, but then specifically perhaps the family's own community clergy person, elders in the society who, you know, know the family, but are also can be, for the healthcare team, a resource person in understanding the cultural background and where some of these questions might be grounded.
I could just add one more piece. This is actually based on my dissertation research of interviewing parents about how they made decisions. It was a qualitative study. I thought I was going to end up with this elaborate, you know, sort of algorithm for decision making. And actually what came out of it was a model of parental decision making that's based on what it means to be a good parent. And that shift from what do you want to how do you see yourself and how do you live with the choices that you have to make is a different doorway into the conversation about, you know, what does it mean to you to be a good parent, and how do these choices align with that image of yourself? So I think there's lots of ways to kind of get into the territory of values and what matters. And it takes time, and it takes listening, and really, you know, parents are grieving. often when they're in these situations as well, and trying to help them work through that grief as they are trying to make some really hard decisions that the residue from those decisions they will carry for their lives. And so I think one of the points is also, you know, as clinicians, these are cases that we will experience for a short period of time, but the parents will carry that process with them for the rest of their lives. So it's really an invitation to try to figure out, you know, how do we partner? How do we understand, you know, this shared decision-making? And I think we've all talked about, you know, as Renee said, the pendulum has swung so far this direction that really what we need is to come back into a little bit more balance where the knowledge and skills of clinicians and parents are both valued in that process, so that it's not skewed in either direction.
I just want to raise one other important point, and you sort of alluded to it. I'm sorry. And you sort of alluded to it, and that's who's paying for it. I mean, I hope you all are sort of hearing, you know, what is going on in the amount of time it takes to have those conversations, to gain those kinds of insights. And frankly, I mean, just look around us, and we are in not easy straits from the point of view of paying for it and paying for that kind of care. And, you know, as you know, spoke about in Canada. So we better be thinking about that too.
Any last words or comments before we end? Ivor, use your microphone.
I wanted to add a sort of comment that always comes to mind when these kinds of issues come up for me. And that's, I'm stepping on your territory, Meg, but a very famous Supreme Court case that involved the issue of what happens when parents make inappropriate and bad decisions for their child. It's a famous case, Massachusetts versus Sprint, involving a mother who was a Jehovah's Witness, and it was a labor law, a labor issue, actually. She was sending this child out to proselytize and hand out pamphlets, but it has a clinical implication. And the thing that I remember from this was the statement of the judge. Basically said, his statement was that you can make a martyr, addressing the mother, you can make a martyr of yourself, but you can't not make a martyr of your child. And I think, you know, this is just something that sticks in my mind when we think about cases like this.
So these are complex cases that have huge implications for everyone involved. And we are in a process of trying to figure out how to move forward in a radically changing environment in healthcare. So it's an important conversation about how do we put in place the structures and the skills and resources to help parents make good decisions that they can live with, but also to support our teams who are delivering this care. And you can see from all of us, the impact is a significant one. So thank you all for being here today.